Welcome to the American University Washington College of Law. Thank you everyone for being here, those of you here in person and on Zoom. Quick note that there is live captioning available for those participating on Zoom, and this event is being recorded, and we will post it on our Health Law and Policy Program YouTube page. The Health Law and Policy Program here at WCL is pleased to support the student-led Health Law and Policy Brief on this very timely symposium, Public Health at a Crossroads, reflecting on lessons learned from COVID-19 and strengthening pandemic preparedness. It's hard to believe, but this month marks the 5-year anniversary of the initial COVID-19 lockdowns in the United States. I remember it like it was yesterday. It's been 5 years. The pandemic impacted every aspect of our daily lives. It also exacerbated inequities in our healthcare landscape, and it strained our public health infrastructure. There are certainly some lessons we learned from the COVID-19 pandemic, but we are also still faced with many current ongoing challenges, including reductions in our public health workforce, curtailing of funding for important research initiatives, constraints on the flow of information and data sharing, distrust of vaccines and challenges to vaccine technology, and growing threats from new diseases and old diseases, measles, bird flu, and more. And all of this within a context of broader threats to our democracy under the current presidential administration. So in light of all of these considerations, we have gathered experts across a range of disciplines and perspectives to share their insights, to provide education, and most importantly, to inspire us to action in this crucial moment. This program is so important and timely, and so I really want to thank the many people in our community who worked very hard to bring this together today. WCL's wonderful staff have worked behind the scenes for many weeks to ensure that everything runs smoothly. So we want to thank our catering department, our facilities department, our AV team, including Ryan Say, and our special events team, including Courtney Watson. I also want to especially thank our Health Law and Policy Program Director, Professor Asha Shelzo, who helped to organize speakers and who will be leading our second panel discussion today, and our wonderful program coordinator, Tamina Asif. I want to thank both of them for their help in supporting our student leaders in organizing this event. But most importantly, I want to thank the student organizers of this Health Law and Policy Brief event, our symposium director, Harrison Faraci, and the editor-in-chief, Julia Pastori. Their thoughtfulness, their exceptional leadership, and their dedication and passion for exploring critical health law issues have been instrumental in bringing this symposium to life. As student leaders, they effectively advance our law school mission, and they inspire others to step up to leadership to tackle these challenging issues facing the healthcare industry and our community. So thank you to everyone, and I'm pleased to now turn the program over to Julia and Harrison. Thank you.
Good afternoon, everyone. Thank you for joining us today. I'm Julia Pastori, Editor-in-Chief of the Health Law and Policy Brief here at WCL. The brief is a student-run publication dedicated to exploring emerging issues in health law and policy. Our mission is to provide a platform for legal scholarship and foster a meaningful discussion on the legal and policy issues shaping this field. We publish 2 issues annually and maintain a blog that covers a wide range of health law and policy topics. As law students, we engage with these issues in and out of the classroom, questioning, debating, and searching for solutions, but no single perspective is enough. That's why conversations like today's, which bring together experts from diverse fields, are so valuable. They broaden our perspectives and help connect law, policy, and practice. So on behalf of the brief, I want to thank you all for being here, sharing your insights, and being part of this discussion. So that'll turn it over to Harrison.
Thank you so much, Julia. When Julia and I were thinking about topics for the symposium, we came to the sudden and somewhat uncomfortable realization that in March 2025, it will have been 5 years since the first kind of lockdowns of COVID-19. And once we made that realization, we found our topic, and working with the Health Law and Policy Program, we were able to craft a really exciting event for all of you. Our first panel of expert panelists will discuss lessons learned from COVID-19 and how they can inform future pandemic preparedness, particularly in the face of rising distrust in public health institutions, followed by our second panel, which will address challenges facing the healthcare workforce. Just to give a disclaimer, I would like to note that on the outside, or for all of our panelists, on behalf of all of our panelists, that each speaker is sharing their insights in their own personal capacity, and that not on behalf of the organization that they represent. I really want to thank our distinguished panelists today for taking the time to address these important questions. We have a really exciting conversation for everyone. Now, I'm very pleased to introduce the moderator of our first panel, Professor Celeste Davis. She was actually my own professor when I was a freshman at American University when I was taking Intro to Health Promotion. So it's really great to have her back here. And she is, as I said before, she is a professor, and she is also the director of the Public Health Scholars Program. She is also a professor within the Health Studies Department at American University. So she brings a wonderful wealth of knowledge and experience to this conversation today. And with that, I'll turn things over to Professor Celeste Davis.
Thank you, Harrison. It's good to see you. I also do want to shout out one of the current scholars is here in the audience. And so I'm glad that there's some connection between the undergraduate campus and the law school as well. I'll kick us off and I'll introduce our panelists. I do want to note that there are longer bios of the panelists on the symposium webpage, but I will start with who we have here. So first we have Brent Ewig, who is the Chief Policy and Government Relations Officer at the Association of Immunization Managers. Brent has nearly 30 years of experience in public health advocacy. He's worked with the WHO, EMPHS, and ASTO, and co-authored Vaccinating America. He holds a master's in health policy from Johns Hopkins. Next, we have Sam Halabi, who is the director of the Center for Transformational Health Law at Georgetown University. Sam is a health law expert with 5 books and over 80 publications. He has advised the WHO, the World Bank, and COVAX, and serves on the WHO's working group on AI and health. And last but not least, we have Sam Hurley, who is the Senior Deputy Director of Health Systems and Preparedness at DC Health. Sam oversees healthcare regulation and emergency response. He previously led Maine's EMS system and holds advanced degrees in public health and emergency management from Georgetown and Emory. Welcome to all of you today, and I'm excited for our conversation that we'll have. One reason why we organized this panel was to educate and to make connections and inspire critical thinking and future action. There are numerous lessons learned from the COVID-19 pandemic, which we can all attest to, and significant questions arising about the strength of our public health preparedness. Our goal today is to focus our discussion on the intersection of public health and law and policy. Sam Hurley, I'm going to kick us off with you and ask you to help us set the foundation by providing a brief outline or framework of the challenges that we faced during the pandemic that continue to challenge our public health preparedness.
Thank you, and thank you for having me here today. So when we had our pre-panel discussion, this was the first question of how are we going to frame this conversation? And I instantly went back to, I COVIDed, that's not a word, but I made it up, in Maine. And so I was not here during the pandemic, but I was in Maine in a similar position. But the lessons learned in Maine and the lessons learned in DC, because I ended up having to help write the after action report for DC, even though it wasn't here. So I know the lessons learned are the same. Basically center around 5 particular areas, and these are big buckets per se. One of them is one that was referenced during our initial introduction, and I appreciate that reference of misinformation and disinformation. We understand that there are, from our law enforcement professionals, there are actors, foreign actors, state actors, who are influencing the information that we as consumers, whether we be law students or whether we be lay persons in the community, they're influencing the information that we are consuming, that, on our social media sites, on other forums. And by influencing that information, it manifests itself in vaccine hesitancy. It manifests itself in distrust of government systems. It manifests itself in a myriad of different ways. But it is something that we have to acknowledge that was ever present and came to a head during the pandemic, that we are continuously trying to manage and address as we move forward. So misinformation, disinformation, so information. The next thing is infrastructure. And, the title of the administration that I oversee is the Health Systems and Preparedness Administration. I know many of you are law students or are looking into a career in law. But when we think about the healthcare system, unfortunately, there has been a trend over time for the healthcare system to be somewhat siloed. You may have experienced that personally, where you go to a doctor and they say, oh, you need to go to this doctor. There isn't a warm handoff or a smooth transition between that. It's you need to figure out how to schedule an appointment with the specialist and go to a different location, or you need to have some kind of radiological exam, so a CT scan that they can't do at this location. So unfortunately, what we've seen is the healthcare system become more and more siloed. And so it doesn't smoothly work together, and there isn't that cohesiveness. What that has done, and in the pandemic particularly, it highlighted the siloed nature of our healthcare system and leveraging the capacity of our healthcare system in totality to respond to a public health emergency. So for example, in Maine, we leveraged the emergency medical services professionals, so paramedics, EMTs, to help vaccinate. Almost 10% of the population in Maine was vaccinated by a paramedic or an EMT in Maine. EMS is the most ubiquitous healthcare system we have in the United States. If you call 911, no matter where you are, there is going to be an ambulance that comes. It may take a while. It may take a while if you're in rural Montana or wherever you may be. It may take a while, but there's going to be someone that comes. There isn't a doctor in every county. There isn't a doctor in every town, but there is someone like EMS. There are jurisdictions in the United States who could not use EMS because they had a siloed approach and they weren't thinking about the capacity of the system in totality. This is going to become more present in the second panel that y'all have about workforce, but it's how do we leverage and change policy based on the lessons learned from the pandemic to ensure that we are fully utilizing and exercising the total capacity of our healthcare system to meet our needs. So infrastructure and the healthcare system, making sure that we increase cohesiveness, and we talk about capacity. Also within that are data systems. We found that during the pandemic, it is imperative that we had high quality data systems for exchange of information. I will tell you there were billions, and that's with a B, billions of dollars thrown at data systems to try and be able to bring us up to speed to be able to do the things that we need to do. One of the problems now is we have elected officials who expect to see those same instant data results that they saw during the pandemic. You could see what was the number of positive cases of COVID-19. You could see the numbers from yesterday in, today, or you could see them in real time in some jurisdictions. The problem with that is that took billions of dollars for one infectious disease. And so we have elected officials that I have presented in front of council, and they say, well, can you tell us these numbers? Our data systems aren't built to do that at this point in time. So when you as law students, as you take on the mantle of addressing some of these health policy concerns, it is ensuring that we have data systems and infrastructure to make that work. The next thing is regulatory flexibility. So during COVID-19, there was a massive shift in regulatory structure. There were jurisdictions who did allow EMS clinicians and did have that flexibility, that they made changes to their laws or made changes to their regulations. So that is one of the big avenues by which we identified through COVID is we need to ensure that we have regulatory flexibility. And we need to increase our collaboration and coordination between government and industry. You're going to hear from our partners at this table about, well, Alex is not here, so you may not, you're going to hear maybe something like this, but you're going to hear about the importance of the collaboration and capacity to coordinate between government and industry. Operation Warp Speed, as troublesome as it may have been, despite your perspective, it effectively delivered an mRNA vaccine. There may be problems, but that was a coordination between an immense amount of industry and private partnerships and government. And so it's imperative that we increase and focus on that collaboration coordination. And then response framework, making sure that we have a response framework that is consistent across our domains. DC is a prime example of where that is problematic. If the DC director of the Department of Health, Dr. Ayanna Bennett, gets in front of the news cameras and says, do not drink the water, and then the PG health director gets on the news cameras and says, the water is fine, it's the same news channel. So how do you have that conversation when we have different guidance? You saw it. If you turned on a TV during the pandemic, you saw it because there were some states issuing guidance A, there were some states issuing guidance B, there were counties within the states issuing different guidance, there were nations issuing different guidance. So ensuring that we have a response framework, it doesn't have to be exactly the same, but it does need to have some congruency and overlap so that we aren't saying white versus black, because that's what ended up happening. So that's kind of the framework where I frame our conversation. And I'm sorry that took a while, but I think those 5 buckets are where we're going to fall.
Great, thank you. We appreciate that. So Brent, building on this foundation, can you take us through the COVID-19 response and thinking about the challenges faced and the lessons learned with respect to vaccine development and the role of vaccination?
I'd be glad to. And first, let me say thank you for the invitation to be here. I should note, actually, I'm a fill-in for a colleague of mine, Dr. Shelley Fiskus, was originally scheduled, had a family emergency. So thank you for taking me. She's brilliant. She's a pediatrician. She's an amazing communicator. But I did learn in working with her that you have to be really careful in working with pediatricians. Does anybody know why? They have really little patience. Okay, thank you. So 3 reasons why I'm glad to be here. 1, free pizza. So that was great. 2, as having a near 30-year career in public health advocacy, that sometimes one of the things your parents don't quite ever understand what you do in your day job. But every time I got invited to a university, my mom would go, well, my son's a guest lecturer. And she'd go around and tell all the neighborhood friends, my son's speaking at a university. And my mom passed away last year. I'm sorry, but this honors her memory. And I'm sure she's looking down going, well, my son's a guest lecturer. And the 3rd reason is that I've spent the summer as a Washington intern, DC intern, when I was in college. And I stayed at one of the dorms down here and learned that John Kennedy gave one of the best speeches in all political history, the World Peace Speech. And so I see some people nodding. If you haven't seen it, go down. There's a plaque. Nope, I almost turned myself off. And listen to the speech on YouTube. It's only about 15 minutes, and it is just it's the height of effective political rhetoric. And he was talking about re-examining our attitudes with the Soviet Union, re-examining American attitudes, and one of the, just so much brilliance in there. And one line that sticks out is that our problems are man-made and therefore can be solved by man. And so I think there's some, we want to be inspirational today. That's my inspirational tip is learn that speech and the lessons there. So I'm going to walk through a little bit more on the specifics around the vaccine campaign in particular, and I'll try to highlight, recognizing your law students, some of the key legal issues. And doing this from the perspective of a book that I wrote with a colleague of mine who at the time was the head of the Association of State and Territorial Health Officials, Mike Fraser, and we put together a book. He was concerned that we were losing the narrative, that the narrative of COVID response was that we had failed. We had failed in testing, we had failed in messaging. And at the time he pitched the idea, the vaccine distribution was going pretty well. And I think you all have seen how that's played out over time. But he said, let's tell that story. It's the story of how we got 600 million vaccines out to every corner of America within a year. It's never been done before. So we put together this book, Vaccinating America. And I gotta be honest, I was feeling pretty cool that I was an author, and then they put me next to the guy that was 5 books. Wah, wah. But congratulations, that's amazing. So what did we find? This was the idea that you always start with the bottom line up front. The COVID vaccination campaign has been credited with saving 3.2 million lives and over $1 trillion, and that's mostly through avoided hospitalization. So I know, you hear every day this noise about, mRNA vaccines. Are we still sure they're safe? And the backlash that was clear on the efforts to mandate them and other things. But I think the point we wanted to get across in the book was this was a huge success in helping to end the pandemic, return us to some sense of normalcy, stopping the shutdowns. So that's a Commonwealth Fund analysis. And like I said, using that lesson of try to put the bottom line up front. But getting a little deeper into it, just want to touch on one of the kind of major themes that we found that we try to explain in the book. 5 main things: that funding matters, and I'll explain what that means. Trust matters, that came up in the introduction, and just acknowledging we've lost a lot of trust, but it's not as bad, I think, as reported. Coordinated global, national, local. There's a word called glocal, where you combine global actions with local actions. And again, I'm looking to my colleague that's worked with the WHO. Quick sidebar, I COVIDed in Geneva, Switzerland, not because I was smart enough to get a job in Geneva, but my wife was. She was working at the World Trade Organization, and so I got to be what's called the trailing spouse. Going to Geneva, my job was to arrange ski trips for my kids for the 5 years that we were there, and also gave me some time to consult and write the book. But that's that combination of having that coordinated global to national to local action. I think Tom Frieden, who's a former director of the CDC, said it best, that the next pandemic is only a short plane ride away. So we have to have those connections. Nonpartisanship matters. Again, we lost the narrative on that. Things in public health have become intensely partisan. I should mention, I work for a nonpartisan organization, and it's really hard to work to be nonpartisan in these very partisan times, but that matters. And then leadership matters. And my colleague here to the right worked in Maine at the time. You mentioned Maine had one of the best secretaries of health, who then went on to be a deputy director at the CDC, and I think was a model of how you meet people where they are in your messaging, sometimes with humor, but giving the facts. And so leadership clearly matters. I know my time is short, but I'm going to get into just a little bit of detail. We had mentioned warp speed, which again, Trump administration. Does that mean I ran out of time? Sorry. The Trump administration's effort to speed the development of both vaccines and therapeutics. And so this was a great success, and it's unfortunate that it's not celebrated as the great success that it is. But when we looked at that in detail, and from the perspective of state health agencies that were partners in the planning, but never full partners, there's a number of themes that came out that I wanted to share, because I think, this is about lessons learned. The idea that we had in the book was we had to document how hard the planning process was and the mistakes that were made in case we ever have to do it again, so we don't repeat those. And God forbid we need a national bird flu campaign, we would be back to square one. What happened with warp speed is the president essentially put the military in charge of distributing a public health product. And the military is great at getting a pallet of beans and bullets anywhere in the world within 24 hours. But the problem was they thought they could do the same with vaccines, that they saw their mission as delivering the vaccine to the either the pharmacy or the hospital delivery doc. And they didn't have the training or the expertise or the knowledge to know how to get that last mile to get the vaccines from the delivery port into people's arms. And the tragedy was the folks that I work with now have been doing this for 30 years. They run the Vaccines for Children's program, deliver 74 million doses of childhood vaccines every year, have very sophisticated provider networks and delivery networks in place. And the military guys came in and said, let's contract this out like we do in the military, and we will show our kind of logistics expertise. And so there was just a major clash of culture. And so some of the things they did is that they sidelined the public health voices. They saw the public health people as more interested in publishing and doing research than in action, and that was just a misperception. As I mentioned, they defined the mission too narrowly. They defined it as, does our delivery get there, and can we track where the vaccine is delivered? Like I said, they delayed their engagement with the on-the-ground frontline state public health leaders. And this was because when you have a general, he's used to saying to people, give me the information, and they get the information. In public health, we have a culture of collaboration, and let's talk it through, and let's not rush things that we might have to redo or undo later. And so there was again, that real clash of cultures, but they would talk to the governors and thinking, well, you know, we can talk to the governors, and that means we've talked to the state. And there was a gap between what the governors knew and what their state health officials knew. And so that was, again, a lesson learned that we needed that engagement earlier. They had an avowed preference for the public sector. And what they said is, you know, money is not an object to the vaccine manufacturers, to the distributors, to the pharmacies. They said, you know, whatever it costs, the return on investment is infinite here. So tell us what you need and we'll get it. And with public health, because we're public sector and they didn't have a lot of trust, they said, you're asking for billions of dollars for what? And so it's just a major frustration that they didn't understand. We always use public and private sector direct delivery networks for vaccines, but there is a central role to the public sector in overseeing the entire operation, and that took a long time for them to understand. And then they just had like I said, a sort of a lack of respect for public health expertise. So that were some, in a nutshell, what some of the real challenges were. And again, you know, that's pretty blunt, and I realize I'm criticizing people who have dedicated their lives to service to our nation. So I don't mean it in a personal way. And I talked to some of them as part of the book, and we just kind of agreed that we had fundamental disagreements about the role of the public sector and things like that. I know, should I take 1 more minute? Is that good? Funding is central, and that was an issue from the beginning where, like, as I said, the warp speed people said to the manufacturers, tell us what you need, tell us what, and we'll get it. There was huge delays in getting money to both the CDC and then the CDC to get it to the states. And what they started with was just a planning grant, $200 million that was before the vaccine came. And then Congress in December approved $4.5 billion for vaccine distribution. And they had some pretty good, you know, usually when Congress provides money, it takes months to get it out. They had some provisions, get stuff out within 21 days. But the bottom line, what happened was the vaccine arrived before the money arrived to the health departments to help oversee its distribution. And so if you remember those days, those early days of the vaccine distribution, it being a little chaotic and promising, you know, there'll be tens of millions of doses, and then there wasn't, and we're going to have it at CVS, and they didn't, but Walgreens did. A lot of that was just because of this delay in getting the money to the people that were on the front lines. And so that's, again, one of the things we learned. I think a lesson learned is if we're facing another pandemic, we need to get that, we need to convince Congress to get that money out upfront and not wait until, again, the vaccine arrived before the money really arrived to distribute it. I'm going to stop there, and then we've got time a little bit for kind of bigger key takeaways, but I will turn over. I don't know if you need this.
No, we're good.
Yep.
Thank you, Brent, for that. And thank you for introducing, at least to me, the term global. I just returned from a spring break trip with 12 undergraduate students and 1 graduate student to Brazil. And it was a learning trip. But we were thinking about just health implications of maternal mortality in Brazil, but it brought together this kind of idea that local is global and global is local. So with that, Sam, I was curious about the role of the WHO in the US response to COVID. And then now, how does the US withdrawal from the WHO affect public health and pandemic preparedness as we continue on into the future?
Yeah, thank you. Thank you very much. Can everybody hear me okay? And want to echo the thanks to Asha and Harrison and Julia and Celeste and the health program here at American, which is, if you're a law professor in the United States, American is one of the biggies. And so it's really an honor to be invited to participate in one of their events. I guess I will start with the United States and the World Health Organizations have enjoyed from the WHO's inception an extraordinarily close and collaborative relationship. If you sort of, and now I've had to do this in response to what's going on now, sort of you read congressional records and you read sort of the joint resolution supporting United States entry to the World Health Organization 1948, it is a sort of unbelievable enthusiasm on behalf of Congress, on behalf of the executive branch for this organization that is really going to sort of be dedicated to the eradication of diseases that really burden humans and to some extent animals and plants as well. And it's just a stark contrast to the situation we have today. It is certainly true that from that time and forward, the financial relationship between the United States and the World Health Organization has been unidirectional, right? So the United States provides about a fifth of WHO's budget. It works very close cooperatively, and that's just the formal numbers. When you look at what USAID and CDC do in support of WHO activities, that number is bigger. The informational relationship is not unidirectional, right? So the United States government benefits enormously from the capacity of the World Health Organization to know what's going on the ground, not only in places that end up being the sort of the sources of epidemics and pandemics, but also sort of how to address containment and to work on international disease control agreements. So the most important one of those is the International Health Regulations 2005, and that sort of guides what the entire world is supposed to do in response to something like the COVID-19 pandemic. And that relationship works really well, even at the time that COVID-19 was determined to be a public health emergency of international concern in January of 2020, when it was declared a pandemic in March of 2020, where that relationship really broke down was over this issue of the culpability and responsibility of China in the course of COVID-19. But the fact is that the WHO provided the United States government, as a matter of its own national security and certainly the security of its personnel working worldwide, an enormous amount of information to do good work, not only for its own citizens, for its military, but for the people living in those countries. So now, the United States did not rely on guidance from WHO in the way that a lot of countries do. That's entirely fair, right? The United States is a very high capacity country when it comes to health preparedness and response. As it turns out, there's lots of reasons for our dysfunction, some of which have already been described, a lot of which come to partisanship, a lot of which come to federalism. But the reality is that the United States sort of has worked very closely with WHO and has benefited from its expertise and presence worldwide. As a researcher, if you try to do anything with respect to health in Brazil, health in Nigeria, health in Rwanda, you almost have to go, unless you have good relationships with the governments in those countries, which is often very difficult, you almost have to go through the World Health Organization because it has the trust and the credibility in those countries, and it's just a good thing. It's a good thing for people everywhere, including U.S. citizens who are living in Kansas or Indiana or Arizona. With respect to the United States withdrawal from WHO, I think in some ways the outcomes are pretty closely related to what I just said, right? So I work pretty closely with WHO pretty regularly. I just got back from Geneva last night. So the World Health Organization is having to drastically reprioritize and rethink what it does as an organization. And by and large, that means cutting programs that help very sort of sick and poor people in very difficult conditions worldwide. Again, if you take a look at what happens in domino or knock-on effects from those conditions, it is all of the things that make everybody less rather than more secure, right? So if you have less fed people, there is more distrust, there is more sort of dissatisfaction, there are more conditions for the kind of people who are more than happy to resist what the United States does violently or militarily, right? So it isn't just that the United States is going to save. By the way, the operating budget of the World Health Organization is sort of between $4 and $6 billion. It is a rounding error in the context of the United States budget. You are not saving big dollars by withdrawal. What you're doing is taking the magnification effects of a single US dollar in places like Kenya or Cameroon and really devastating local business owners, women, people who need access to HIV medications. And so the US withdrawal, other than sort of representing this punishment of an organization that does a lot of good will ultimately make all of us less secure. And I'll just sort of part with this thought on U.S. withdrawal is that the supposed reason that the Trump administration in version 1 sort of announced withdrawal from the WHO, which never materialized because the Trump lost the election, or like, so we think, in 2020, was over this issue of the WHO's sort of refusal to be hard-nosed with respect to China's responsibility for COVID-19. When on January 20th, 2025, Trump announced withdrawal from the WHO, right? Sort of you had some of that language. What you haven't seen is a corresponding bilateral effort by the United States government to really bring the forces of investigation or security to bear on that issue. So it just seems pretextual, right? We say that we cared about WHO's flaws when it had to do with China. Now we announce our withdrawal from the WHO, but we're not going to raise that as any kind of primary priority diplomatic issue in the normal course of our dealings. So I think I'll leave it there.
Great. Thank you. Thank you all for providing that context. We're going to move now to thinking about our current climate and how we respond to the next pandemic. So I'm going to address this broad question to all of the panelists. With the looming public health threats such as H5N1, measles, tuberculosis, a climate of weakening public health infrastructure, growing mistrust, I could go on and on. How do we navigate these challenges as they're all coming at the same time, and thinking about what are the most critical actions we have to take now? Anyone kick us off?
Well, I'll start just because my attention has been focused on it sort of very specifically and very recently, although it's ground that I think might be better covered by Brett and Sam. It sounds silly, but to do the things that we used to do is a matter of course, right? So when you think about access to immunizations, especially H5N1, where we're really just waiting for sustained human-to-human transmission for it to be a terrifying human public health threat. There are sort of two components of the United States government that typically are very good. On the product side, you have the FDA Advisory Committee on Vaccines and Biologics. Its most recent meeting was canceled without explanation and not rescheduled by the US government. And then on the public health side, you have the Advisory Committee on Immunization Practices, which is sort of being threatened to have its entire membership sort of reappointed for people who we think might share the skepticism of vaccines generally, right? So you have these two parts of the US government that have historically been exceptional in reviewing evidence and making public health recommendations. A lot of you in the crowd might think that the FDA essentially has a public health mandate, right? It's supposed to not only approve vaccines for safety and efficacy, it is also supposed to give guidance as to who should take them: women, children, the elderly, and it doesn't, right? It reviews evidence and approves marketing authorizations. We rely on CDC and its expertise to drive the things like where the vaccination should go, whether or not they should be given to populations that aren't indicated on the evidence, right? So children are often not sort of studied in a clinical setting for good reasons. Pregnant women are often not sort of part of double-blind, well-controlled trials for good reasons. And so we really rely on both of those parts of our government to be robust and doing their jobs regularly and effectively. The worst thing you can do is just cancel their meetings, take away their money, and then replace them with people who are going to scare people away from the thing that works best in a crisis.
I'll pick that up because I mean, we talked about this trust being the center of what's been lost. I have a job where I get to talk to people on Capitol Hill on both sides of the aisle, and a lot of what I'm doing these days is trying to regain common ground. And so you mentioned, previous to the pandemic, vaccines were routine. You know, kids, 95% of entering kindergartners had all the vaccines that were recommended. In fact, it was so routine that when I was contemplating taking this job, I thought, who would want to work on immunizations? It must be boring. It's routine with me, you know, a seasonal ramp up of flu season. Pandemic, not so routine anymore. So one of the things I do is just kind of get the numbers out to people that, you hear a lot about distrust in vaccines and lowered rates, and that's true. But we're at like 92% for kindergartners have their vaccine. So parents are still far and wide, they're choosing to vaccinate their children. Even the COVID vaccine, as politicized as that was, 80% of adults got at least the first dose. And when you get to polling for support for school requirements, let me quick do timeout. I feel like a law school, I could do professors. Anyone know what is the Supreme Court case that established the constitutionality of vaccine requirements? Anyone?
Jacobson.
There we go. Gold star. Yeah, Jacobson versus Massachusetts. I mean, that was the heart of the legal issues when the Biden administration went to a COVID vaccine mandate is that has somewhat a power that's typically been reserved through the 10th Amendment to the states, the state power. That was unique to see the federal government try the employer angle on that through the Department of Labor, and it didn't hold up. So that was an interesting legal test. I got off point there. The point being that when you ask parents, do you still support school requirements for vaccines, it's not great. It's dropped pretty significantly, but it's still in political terms is landslide. 60% election win is a landslide, and we're above that on this. So for people on the Hill that understand politics, that's my message to them is there's still landslide support out there for vaccines. I know you're hearing from constituents, a strong and vocal minority, but you need to consider the majority of where Americans are. And that helps regain some common ground. And then even more appealing common ground messages, no one wants to see people suffer from things that are preventable. So we've seen 2 kids die from measles. Well, one, I think in New Mexico is actually adult. 2 people die from measles in the 21st century. Shouldn't happen in America. And it doesn't get headlines, but just in the middle week of March, 20 children died from flu. And tens of thousands of adults this last flu season. It doesn't make the headlines, but again, largely preventable. It's not only tragic loss, but it's a drag on the economy. So coming back to that common ground message, again, I think is where we're trying to push the debate.
If you know the answer, please come see me after. So I think we're in a unique position in DC government because we are not a city. We are a city, pardon me. We are not a county. We are not a state. We are now technically a federal agency, according to the last budget submission. So it is one of those things where we have home rule, kind of, so we're supposed to. Except there have been significant ongoing threats to our home rule and our autonomy. And so we sit in a very unique spot. I mean, if you have been watching the news, you've seen the threat of a $1.1 billion cut to our budget this year because we're going to revert back to a previous budget period. Whereas those were monies that we collected in taxes, but we can't spend our own tax dollars. So it is one of those things where we're in a very unique position in the district. So taking that in perspective and stepping back a step from that. So looking at it from DC and like a main perspective, I think the most important action for us as public health leaders in the government space is really identifying our functional domains right now. And where are the public health functions that we have and that we need to support? Because the cuts are coming somewhere, whether it's in HIV funding, whether it's in public health response funding, hopefully not there, but the cuts are coming as this administration takes the stance of, hey, we want to reduce the federal budget. They're coming. So as a public health preparedness person, the most important thing and action step for me to do right now is to identify the functions and the costs and essential items that fall under each of those functions, whether that means immunization. What does it cost for me to have an immunization program? What does it cost for me to have strategic national stockpile warehouse program? What does it cost for me to do these particular functions? Because when I'm having these conversations with either our federal partners, or I'm having these conversations with our local partners, or if I am in Maine and I'm having conversations with the state government, I need to be able to clearly articulate what functions we have to maintain. And I need to be able to associate functions with outcomes. So if I can say this function, if you eliminate function A, you are going to cost 10,000 lives. Now I start, and it is terrible that we have to detail this way, but I have to clearly articulate to them the risk associated with the action that you're going to take. So if you do this, here is the outcome. Because either way, I'm going to fill the cut. So how do I make sure I clearly articulate the functions, the functional groups that I have under public health response, preparedness, and general public health activities, so that I can withstand the cuts to maintain those mission critical items that I know I need to pay for a child immunization program. Because if children aren't immunized, we're going to have people dying of polio. Let's not do that. So I know I need to pay for that. So that's in like this mission critical section. But if there is something like health education, I would argue it's mission critical, but I need to be able to translate that health education to lives saved. I can more easily translate the polio vaccination campaigns than I can the health education campaign. And if I have to cut because I am subject to the whims of the federal government, if you're in a state government, I'm subject to those things. I need to be able to clearly articulate that. And so that's really that's what we need to do as state leaders, because we already have plans for pandemic response and those types of things, which in many places were updated. So like H5N1, we have a response plan that we can transition into activation, but I need to know what functional capacities fall under that response plan. Because if I don't know what I need, then I'm going to let them cut something and whoops, I needed that. And building it back up after we're in response mode, very problematic.
Thank you, Sam. That makes me think about, right, very clearly understanding where in government your role is and what those functions are. If we're looking to the future and how to be successful with the next response, given what's happening now, how do you then collaborate with private partners and understanding where they might be able to fill in those gaps or what their responsibilities might be? And anyone can answer this as well.
You'll just love hearing me talk. So it really goes back to, once we identify those functions, those private partners are the same ones who are going to the hearing saying and testifying in front of the legislature saying, this is a terrible idea, don't do it, don't do it. And then they do it. So those are the same partners. So if we are clearly articulating the functions that if you cut this, you're going to cut functions A, B, and C. This is the cost of A, B, and C, not necessarily monetarily, but this is the cost in lives or, potential life lost on ABC. It allows us to have that conversation with the private partners and collaboratively to say, hey, where can you help us navigate the gap between this? Because, for instance, when we talk about immunization programming, there is an interest in the private sector to have a public health marketing campaign because that's how they have increased uptake in purchasing of the vaccines that they are selling. So if I can potentially help them shift into that health marketing space, yes, I know that is a little bit problematic that we're having to have our private partners pay for public health promotion, but it is one of those things of how do I leverage my partnerships to do that, to help support and the stopgaps. So it's understanding that so that you can engage in those conversations, because they're going to know where the gaps are and how it's going to affect them. And people have capitalized, welcome to capitalism, people have capitalized on our public health infrastructure and public health systems. And so identifying our mutually aligned goals is really imperative here.
I just want to note also that wasn't a silent protest. Students have class at 1 o'clock. And so that is why there was a swift departure. I'll invite both Brent and Sam also to give any input to that collaboration kind of question.
Not much to add, just on an endorsement of that message, the economic interests and the cost effectiveness of public health interventions. And I'll admit it's complicated because there were a lot of businesses that now feel like they were shut down longer than they should have been because of public health decisions. And it's that fundamental tension between saving lives and saving livelihoods. And I think we as a nation haven't done a good enough examination of that post-pandemic of how to better do that. But I think your instinct to make that messaging resonate and to have businesses understand a healthy workforce, a healthy community, protection against health emergencies is in all of our best interests.
Yeah, and I'll just add, because I think it is a persistent conversation, and I think I can say it in a way that isn't critical of any given constituency. Sort of diseases are sort of scary and they are costly. And I think you can actually get a whole lot of people onto the same page if you sort of acknowledge those things to be true and really think through all of the measures that are win-wins. And there's a long list of those, right? So school closures, business closures, like those are hard, and they remain to this day one of, now the budgets are evaporating, but sort of like really studying what those interventions got us over the course of the pandemic that are truly evidence-based, because there wasn't a ton of evidence at the time on things like masks and school closures. And if you work in the comparative space, there was significant differences between what countries did, especially with respect to school closures for young children and or not, right? And so, vaccines are just it's just a no-brainer, right? Everybody should be on the same page with something that for the lives and cost of illness they are just pennies on the dollar, and probably less than pennies of the dollar. And I have discovered, so I'm from this small county in Kansas. My whole family is sort of like probably more supportive or skeptical of the measures that we are discussing. So, sort of lightly here. And I have found that those kinds of discourses resonate, right? Sort of like when you really sort of talk to people about sort of what disease costs versus what might scare you about a vaccine, it's persuasive. And so way back to Sam's earlier point about disinformation and misinformation, I actually believe that there are credible and good ways to have that conversation. Sadly, they are unlikely to be supported by the current Secretary of Health and Human Services.
Great. We have about 5 minutes left. I know, Brent, you had some key takeaways that you wanted to share, and I think we can close on those.
Sure. So a little bit on where we go from here. And I know that the purpose of this seminar, and thank you again for putting it together, is what are the lessons learned from the pandemic? I'll say one of the things we haven't done is, as a nation, there was we had 9/11, there was a 9/11 commission, independent, broadly bipartisan, and a lot of laws were changed based on that. It's why you take your shoes off when you go through airport security now. And there was no parallel effort, even though it was, I think, maybe 2,000 lives lost on 9/11, over 1 million in COVID, and yet the political fissures were such that they couldn't even get agreement for Congress to ask for a synthesis of the lessons learned. So kudos to you for at least having that curiosity to have a seminar on it today. And again, I know we could do this for a week, but that's kind of a takeaway is we haven't documented and we haven't changed any laws. We certainly haven't strengthened our public health system. And so that's one of them. I think, again, this month, when we all think back where we were 5 years ago, so much has been lost, not only the lives and the livelihoods, but that's an important thing that we take that time to remember. And, there were efforts early on to honor the first responders and remember the people with, banging the pots and pans for people, the healthcare workers, and so much of that faded. And so many public health workers that were doing their best 7 days a week to save lives started becoming the targets of harassment and all, even threatened violence. A quick story, one of our immunization program managers, she got an email and she was able to joke about it. She said it wasn't a direct death threat. It didn't say we're going to kill you. It just said you should be hung for promoting these vaccines to children. And so she had to notify the state police and they had to watch her house for a few days. I mean, that's the level of just the breakdown of community that we saw there. So remembering that and honoring those that worked and continue to work through that. The biggest thing is this panic of, a cycle of panic and neglect. And we've seen it with Zika. We've seen it, with the first H1N1 in 2009. We saw it with so many public health emergencies where we belatedly ramp up funding, and as soon as the crisis is passed, we go back to status quo, or in this case, possibly worse. So we have to find a way to break that cycle. And then again, I'd already kind of talked about common ground, so I think that was important. I want to say to you all, the training you're getting here as both experts in public health law and as advocates is going to be critical. And so I envy you all. I should have mentioned I went to Hopkins. I was pre-law, got diverted into public health school instead. And the last class I took was public health law. And it was so intellectually stimulating that I thought, why don't I just stay on and get a joint degree? And then I looked at my loan balance and I went, oh, that's fine. So I can sympathize with you that are making an investment, but the skills you're developing, and I want to end on this kind of positive note. People ask me, there's so many dark clouds on the horizon, so many challenges, so much just whack-a-mole. One day it's this executive order, the next day it's this congressional funding proposal. It's hard, but I have confidence that three things will get us through. And one is by telling better stories. And that's so key that there's a saying, policymakers will forget your data, but they'll remember your stories. And the asterisk on that is if you don't have the data, you'll get dinged. So you have to have the data, but you have to have stories that make it personal. And we're getting that now with what's happening across America. We're at 300 measles cases. If this continues to spread and we can't contain this, we will lose our measles elimination status. And that's not where we want to be as a country. We have compelling stories about what's happening in communities that doesn't need to happen, that's preventable. We have strengthening coalitions, and that's particular to my field of immunization. There's a number of groups that have stepped up and say we need more presence in state capitals. We need more coordination, and that's growing. But coalitions, we're not out here alone. There's many other voices that are with us now. And then this just gets real inside baseball, but congressional champions. You have to have champions for your issue. And you wouldn't maybe believe it when you watch Fox News, but there are members of Congress on both sides of the aisle that support immunizations. Those that are Republican will say, don't ask me to do something that's going to get me on Fox News tonight and have my phone lines flooded tomorrow with angry constituents. But when the door is closed, if we're talking about your funding, we will be quietly supportive as best we can. So those three things help me sleep a little better at night: stories, coalitions, and champions. And for those of you that are looking to get into advocacy and put your legal training to work, I think those are things that will serve you well.
Great, thank you. And thank you to you all. I just also have a side note. I also looked at my loan balance, decided on that second JD degree, but my loans were forgiven last night. So public service, it pays off. You will be okay at the end of the day. But I want to thank all of our panelists. We know that this is a very complex issue that we'll continue to grapple with as this administration continues to roll on. The next panel will dive deeper into those workforce issues that Brent just started to pull up a little bit. And so hopefully you'll be able to stay for that. But thank you all again for this thoughtful conversation that could go on much longer, but it was really rich. Thank you.
Welcome back, everybody, in person and on Zoom. I know we still have a great crowd across the country. Thank you for joining us. I think we had a fantastic first panel, and people can just see the richness of this topic. And what we've done here with the program and working with our fantastic student leaders is to try to think about, this is a very broad topic. It is very complex, but how do we take a deeper dive into one very important aspect, and that is the workforce. In the healthcare system, in the industry, in the public health workforce, those who are day-to-day trying to tackle these issues, but amidst day-to-day healthcare that is being provided, right? Healthcare, we always talk about it, it's like a 7-Eleven. For those of you who live in this area, it's 24/7. We never shut down, right? There's never a day where we do inventory or we get to just stop and do maintenance. We are 24/7 having a healthcare system that we need to be up and running and functional. So today we're going to focus on understanding the workforce components of this. We have a fantastic panel. I'm going to read only very, very brief bios just to get us going so we can get to the content. but I hope people look at the Health on Policy Brief Symposium webpage, where you can get full bio information and be able to learn more about our fantastic panel here. Oh, and I should introduce myself. My name is Asha Shelzo. I'm the director of the Health on Policy program here at American University Washington College of Law. And I'm thrilled again to be part of this conversation. This is an issue that's been percolating for some time now, pre-COVID, honestly. COVID, of course, exacerbated and shed more light on it. And I think even more recently, we're beginning to realize how much of it is a crisis. And I don't use that word lightly. I know that we often use that word a lot. This is a true situation where those of us who are paying close attention recognize the crisis nature of it. And that's why we felt it was important to have this conversation and have it be part of the education that we're doing. And also to be able to give us strategies and tools to think about what we can do and how we can be thoughtful about this in the future and potentially take action with the skills we have as law students, lawyers, advocates, et cetera. So I am joined by, and this is not in any particular order here, Wendy Dean, Dr. Wendy Dean, thank you so much for being here. CEO and co-founder of the Moral Injury of Healthcare. Dr. Dean is a psychiatrist by training and an author, national speaker dedicated to addressing workforce distress in healthcare. She previously worked on medical research in the military field, as well as numerous healthcare innovative projects. Karen Drenkard, Dr. Drenkard, right to my right here, is president of Drenkard Healthcare Consulting. She is a nurse leader with expertise in healthcare strategy and quality management, with many leadership roles that we're going to hopefully hear about in her talk today at AARP, GW Nursing, and Inova Health. Rob Nicoliti, right over here, a labor and employment attorney at Ogletree Deacons. Rob has decades of experience in healthcare labor law, past president of the American Health Law Association, and a fellow of the College of Labor and Employment Lawyers. Mariah Robbins, a research officer at the DeMont, studying the public health workforce. She has a strong background in public health communication and policy, and we're really looking forward to learning some of her insights here around a lot of the data, and we're going to start with that in a minute. And then Dr. Joelle Simpson, right here, we're kind of gone about out of order, Chief of Emergency Medicine and Medical Director for Emergency Preparedness at Children's National Hospital. So Dr. Simpson leads pediatric disaster preparedness efforts and serves on the National Biodefense Science Board. Again, these are just very short versions of the many, many tremendous skills and experiences they bring to this panel. So let us first, and again, thank you all for being here. And I know that many of you heard the first conversation and a lot of these topics resonated with you. You might even have some thoughts you want to add on some of those conversation points that were already illuminated. So feel free to have the conversation now and to just, to add those insights as we go. So I talked a little bit about why we thought about this topic, why we in the industry are really paying attention to these challenges. Now, we sometimes use the word burnout, right? We're going to talk about that. We're going to talk about the words we use and what they mean. We've definitely seen resignations. We've definitely seen stress. We've definitely seen violence, and not to mention shortages and loss of trust. So these are some of the things we want to unpack. So I thought I would maybe ask Mariah, as I referenced already, to talk us a little bit about data. You have been working on critical work with de Beaumont with the Public Health Workforce Interests and Needs Survey. Make sure I got that right. Help us scope the workforce challenges. Help us use some of that research that you've done, which I understand arose prior to COVID, during COVID and post-COVID. So you're going to be able to give us some of that history there in the trends. What do the data reflect? What trends are you seeing with respect to workforce engagement, retention, and stress?
Sure. Hi, everybody. Thank you so much for having me today. My name is Mariah Robbins. I'm a research officer at the de Beaumont Foundation. De Beaumont, for those of you who don't know, is a private philanthropy that's based in Bethesda, Maryland. And we really work on advancing policy, building partnerships, and strengthening public health. So when I talk about public health, we heard a little bit on the first panel about this, but I'm really talking about the folks who are working in governmental public health, in departments of health and departments of public health across our nation at the state and local level. And they're the folks who are working at the community level to prevent disease. And the way that we like to think about public health is that it's the foundation of your house. If it has cracks in it, your house is unstable. And that's really what we saw over COVID. And a lot of that has to do with kind of what we've seen in the past 2 decades in terms of spending for public health and staffing of public health. So as Asha said, I work on a survey called the Public Health Workforce Interests and Needs Survey. It's a nationally representative survey of this governmental public health workforce. And it has been running since 2014. So we have about 10 years of data. It fielded in 2014, 2017, 2021, and most recently in 2024. We are currently analyzing the 2024 data, and that will be released in July, though we'll be doing a first release on those who are 35 and under in the beginning of May. So look out for that if you're curious. But we have a whole host of data. So just to give you a bit of scope and scale. So PH Wins asks questions on satisfaction, intention to leave, training needs. It's a workplace survey to really understand, like, what are those workforce challenges? How are we thinking about recruitment, retention, advancement, and development of our employees in the public health system? And in 2017, we sent the survey to about 100,000 people and received 47,000 responses. In 2021, it was 130,000 people, and we received 45,000 responses. And most recently in 2024, it was 160,000 people, and we received 57,000 responses. So we have hundreds of thousands of responses of data here. And just to share a little bit, I mentioned some of the background on spending and staffing. So before I share some of the richness of this data that we found through PH Wins, just to kind of couch all of this. So healthcare spending in the US, public health receives about 3% of it. So it's a pretty small proportion of what healthcare in general and what we spend on health in the United States. And since 2008, we've seen a drastic decrease in the staffing of the public health system, but there's been no sign that public health needs are decreasing, that the number of services they're providing are decreasing, or that public health is becoming something that's obsolete. And we've seen that during COVID. It was really important. And we also did a study using pre-pandemic data with a couple of our partners. And we found that the workforce, both the state and local level, was short 80,000 employees. And so that means we need an 80% increase of our workforce to meet just the basic community services. That's not even surging for COVID or other emergencies. It's just the basic stuff that people need every day from the public health system. So we were already at a deficit when COVID hit. So what did that mean? What happened there? So we saw a huge opportunity cost when it came to the services that public health provided. Public health affected every level of the workforce. And so what that meant, for example, is our communicable disease workforce, they spent 70 to 80% of their time on COVID throughout the pandemic. And the program area that saw the least amount of utilization for COVID-19 response was the maternal and child health workforce, but still at low points, they were spending 20% of their time, and at high points, they were spending 40+% of their time on COVID-19 response. So it really kind of took away from other services that public health provides. And we talked about vaccines on the first panel. We're seeing those measles outbreaks, and that's an opportunity cost of what was lost while we were working on COVID-19 response. We also did a study where we compared the staff lists from folks who participated in 2017, those agencies that participated in 2017 to the same agencies that participated in 2021. And we saw that 50% of the workforce left between 2017 and 2021. And that increased to about 3/4 of those who were younger in the workforce. So those serving in their positions for 0 to 5 years, or who were 35 years of age or younger in 2017. So again, we kind of saw this huge exodus between 2017 and 2021. But interestingly enough, we also saw less retirements than we expected. However, if trends continue on the exodus of those young folks and the rest of the workforce, and we see the expected retirements, we're expecting a double wave. So how do we recruit and retain employees and kind of maintain some of that institutional knowledge that we gained during COVID, but that we're also currently still gaining today? So lastly, I just want to speak to the stress and burnout, because I know a bunch of my panelists are speaking about that today as well. So in our 2021 survey, we asked a bunch of questions about stress and burnout. And one of the things we found was that 50% of employees reported at least one symptom of PTSD from COVID-19 response. So how does that play into how they're showing up to their jobs today, or if they're even wanting to stay in their jobs? And we also saw that 41% of executives reported being threatened or harassed in their roles. And anecdotally, we saw many articles in mainstream media about that as well. And it was mentioned on the first panel too. And lastly, on that reasons for leaving piece, stress and burnout showed up, both of those showed up in our top 5 reasons for leaving among all employees, which was not the case in 2017. So this has really kind of perpetuated this, this space for public health employees. And I know that's all very dire. There are some positives that came out of here. We learned a lot. I think that there's a lot of things that we can take from here in terms of communication, and I'm sure my other panelists will also speak to that as well. So I'll kind of stop there, but I'm happy to circle back later if anything else comes up.
And thanks for helping to kind of give us that foundation. You know, the earlier panelist said how important stories are, but backed with data, and having that grounding for us is so important. You know, and it came up earlier as well that, to me, one of the moments that I remember so clearly of COVID, I'm sure everyone remembers when they, you know, when the lockdown was first announced, everyone has a memory or moments for that couple of years of life. For me, the moment when I was the most proud to be just an American was when we were cheering for our providers and our healthcare workforce. It was on TV, it was in the news, and people were cheering for them when they would walk out of work. Now, that was a moment when you felt that this is what we are about here. And the reason I mention that moment, that memory, is because I now want to turn to you, Dr. Simpson-Joel, and as a frontline practitioner at Children's National, an example of someone who day to day was at that front line. Tell us about your role during COVID-19. You know, how did clinicians adjust in that moment as the disease was really evolving and the guidance was evolving? So maybe just start with that, and we have some more things to unpack as we go.
Yeah, no, thanks for having me as well. And I'm really excited to see times when the data matches up with our lived experience as the clinician. So I totally attest to all the conclusions you all derived from the mass surveys that you did, because it does align with what our experience was in the emergency department. To give you context, so I run the largest emergency department, high volume emergency department in DC, and certainly probably in the region. We see 100,000 patients total across our 3 emergency departments that we run for Children's National. And I have a staff about 100 clinicians and then about 300 nurses at any given time through our staffing. So a pretty large enterprise that sees the majority of children in the region. The experience we had during the pandemic was certainly, number one, sort of the marriage of public health and medicine, and trying to determine all the elements that we needed to step up to the plate to deliver. And speaking to the things like miscommunication, mistrust, all that stuff that occurred in the early stages when, especially in pediatrics, we did not know how the pandemic affected children. And there was a lot of catastrophizing of what exactly could happen. And also a lot of realization from the pediatric perspective, our workers saying, we care about the infection and what could happen for children. We also care about the impact this is having from a mental health lens, and the long-term impact of having kids isolated and not in the environment where they can thrive. Because most children exist in a system like schools for 30% of their developing lives. And there's a reason for that, for them to thrive, to become productive adults. So when you threaten that, there was a lot of thought among our clinical staff about what can we do, what exists, especially when we see all the, as you mentioned, the cracks that were already in the infrastructure. When you add a crisis on top of it, it just becomes so much more apparent. So one of the sort of buzzwords that came about more so during the pandemic was this concept of moral injury, where, you know, I feel like what I experienced from my team was this idea that I'm happy to be celebrated. I actually don't mind the applause, that's fine. But at the end of the day, I still feel poorly about the fact that I'm not doing enough. And that conflict, and certainly as a leader of the division, having many discussions with the team about, you know, well, what more can we do? Almost you know, my words, nobody else's, but this sort of like guilt of a superhero image that was really saying, but we're still falling short, and we're falling short pretty tremendously. And then, you know, certainly wanting the data, also realizing, as expressed during the pandemic, how do you put boundaries on work and personal space? So you could also take care of your family. So there was this idea of, I need to protect myself, but I want to do more because I understand what is happening to especially our pediatric patients with the impact of this pandemic. It was really hard, especially as leaders in public health and medicine and so forth, to really guide the workforce through that. I think at the end of the day, we did a lot of comparing to what's happening in the adult systems, what's happening in New York, what's happening in California, to sort of, unfortunately, human nature to feel a little bit better, to give context. But at the same time, we knew that nationally, this was a pretty dismal situation, and we should have been doing more to prevent it. Trying to end with some good news. One of the areas that I think has grown pretty significantly, at least through my lens, has been this evolution of disaster medicine as a concept. And the premise, I think, of disaster medicine is that you can't be ready for disaster until you're ready for the everyday. So we are hoping to work and partner with public health and other colleagues in the space looking at these issues to fill in that infrastructure that's needed for the everyday readiness so that we are better ready for future threats. I do know I'm working with a couple colleagues in various disciplines, not just pediatrics, to advocate for actual disaster certification and expertise across medical subspecialties. And I think part of inherent in disaster planning and expertise is public health. I myself have a public health degree, and I am so grateful for that lens as a leader in a clinical space. And so I know I touched on a lot of different topics, but maybe I'll sort of end there because I know there's a lot of follow-up from the other panelists as well.
Thank you. That gives us the real good foundation. And you mentioned this term moral injury, and we would like to turn to Dr. D. Wendy, your work as the co-founder of Moral Injury of Healthcare, the organization. I used the term burnout earlier, but I would love to kind of press on that a little bit with you. I know you shared with me the term betrayal. Tell us a little bit about moral injury, betrayal, how we are in this moment of crisis here.
Am I on? All right.
Sorry. Yeah.
So thank you for that. Thank you for inviting me to join this panel, because lessons learned are one of my favorite things. We don't do it enough. And especially having such a varied perspectives is really amazing. So I'm going to back up a minute and tell a bit of a story, because for me, this starts with, what does it mean to be a healthcare professional? And for me, as a college student, as a high school student, becoming a physician was way more than just choosing a job. It was this inexorable pull that I'm sure a lot of you who came to law school feel as well, towards service, integrity, compassion for your fellow man, trying to do better, being in service, and still having an intellectual rigor. And, you know, for me, it was also being worthy of the trust that my patients give like a gift. Right. And that felt so much bigger than me. And then I got into medical school, and I got into residency, and I got into practice, and I tried way more times than probably is advisable, including changing specialties, including changing how I was working, in what kind of business model I was working, to find a way where I could practice that was good for my patients and sustainable for me. After a decade, I quit. I walked away and started working for the DoD, managing research funding oversight. And there I met a plastic surgeon, arguably at opposite ends of the opposite ends of the medical practice spectrum. And we were at a conference, we were talking, and we realized, holy cow, our experience of medicine is the same. That made no sense to either of us. And we both realized we viewed each other as some of the most resourceful, resilient, efficient clinicians that we knew, yet we were both struggling. We both thought it was about us. And when we did that comparison, we had this epiphany that this is not about me. This is how I'm being asked to work. And what we had heard for decades is that this is about burnout. You need to be resilient. You need to do yoga. You need to be mindful and meditate. And we were like, that's not what it's about. I knew what I was signing up for. I knew I was going to work long hours, see terrible things. I knew all of the hardships of medicine. What I didn't know, though, was how hard it was going to be to get my patients the care they needed. And that's what's breaking me. I can't keep my promise. I can't keep my oath. I can't uphold the oath that I took. And so we started asking everybody around us, other clinicians, other professions, every one of them resonated with that. We didn't have the language for it until I stumbled across this concept of moral injury, which is betrayal by a legitimate authority in a high-stakes situation that causes you to transgress your deeply held moral beliefs or your oaths. And when we started explaining this to people, it resonated powerfully. And oh, by the way, it resonated with public defenders, other lawyers, veterinarians, educators, almost you name it. And what we were hearing in healthcare was that these tough, resourceful, resilient clinicians were trapped between the patient-first values of their Hippocratic oath and the business imperatives of the systems that they were working in. So they knew what their patients needed, but they couldn't get it for them. And I will say this started long before COVID. So on February 24th, 2020, I was in New York City Hall in a cramped hearing room, shoulder to shoulder, not a mask in sight, talking about safety in New York City emergency rooms and the need to address moral injury because of their understaffing, under-resourcing, and overcrowding. So clearly that was not driven by COVID. But what happened in COVID is that this idea, this concept flourished because of some of the situations that folks were in. This sense of wanting to do more, not being able to, not having enough PPE, so that when a patient dies, that is a tragedy. When they die alone because you don't have the PPE to go into the room, because your health system or your government system didn't predict that and didn't prepare for it, that feels like a moral injury. So what we found was that 40% of clinicians endorsed at least one symptom, endorsed moral injury during the pandemic. 45% said they felt betrayed by leaders they once trusted. But the interesting thing was that 40% of leaders and managers also felt some level of moral injury. Either they experienced moral injury, they knew what their employees needed and they couldn't get it for them, or they felt betrayed by some of the guidance and regulations of their government. So, I think what happened, people have talked about that heroes to villains sort of shift that happened. And it was a predictable response. That is a predictable psychological response to disaster that we didn't prepare for. So that was one of the challenges that I think in a coming pandemic, we should think a little bit more broadly about. But what happened in the wake of that is that it accelerated the loss of our workforce. So, 2.5 years out, the people who stayed, who didn't retire early, who didn't leave saying, I can't do this. They stayed in part because they were thinking, okay, when everybody sees the challenges of our healthcare system, we're going to have to make changes. And instead, the rush to get back to business as usual just felt like another betrayal. So we're at a point where 2.5 years out, 24% of respondents in a survey late last year said that they were looking to get out of healthcare, get out of their current jobs within the year. Only 6% of them were retiring. So we're seeing tremendous shifts. And again, people cited stress, poor culture, lack of management support. So what we have is a profound fraying of trust in our healthcare systems that we're not acknowledging and we're not treating. And I think what we need is a hard reset to start recognizing that, the consolidation, the vertical integration, the corporatization and financialization of our healthcare systems is not working for our patients. It's not working for us. And we need to rethink how we deliver care and how we treat those who deliver care, as well as thinking about our patients. I feel like a lot of times when I'm delivering this news to people or this raising awareness about moral injury, it feels like a really kind of dark thing. But I feel like we made the choices to create healthcare the way it is now, which means we can make different choices. But we need to understand how we got here so that we know how to get out and what's already been tried. And we've been making a lot of incremental changes, and I think we really need to step back and take a good hard look at a larger reform or restructuring of healthcare. And there was a great quote by a regenerative agriculture farmer, who's Don Campbell, who said, if you want to make small changes, change the way you do things. If you want to make major changes, change the way you see things. And I think we need to start seeing healthcare in a slightly different way.
Thank you. Thank you so much, Wendy, for those thoughts and helping us really parse this idea of moral injury, the betrayal. I appreciate the superhero guilt concept as well as the hero to villain concept, because when I was reflecting that memory, that moment early on didn't last. And that's why we have this panel. That's why we're having these conversations, because what happened, and understanding what happened is what we can learn from. But also, as we know from the earlier panel and just from reading the news every day, there is a lot more challenges to come where we have to really deploy these lessons, right? But let me turn to you, Rob, because I'm glad, Wendy, you mentioned some of your data, your stats were not just, not only the clinicians, providers, the frontline, but it was also the administration. You mentioned the managers, the supervisors, also facing this moral injury, this betrayal, the stress, et cetera. And Rob, I know the work you do is often representing those stakeholders, whether it's the C-suite, the in-house legal, the compliance function, the human resources function. How are the stakeholders you're working with understanding what's happening? Do they see the burnout as a moral injury? Do they see the betrayal? What's their perception? How can you help us kind of give that perspective?
Sure. So thank you for having me here today. I'm a shareholder with Ogletree Deakins. We're one of the largest labor and employment firms in the country, actually in the world now. We have 59 offices across the country and throughout Europe, Canada, so on and so forth. And we do a lot in healthcare. Specifically, I've been very privileged in my 30+ year career to represent a lot of hospitals in the Baltimore DC corridor. As a firm, we represent close to 1,000 hospitals and health systems throughout the US alone. Dr. Dean and I have had some discussions about some of these words and about perspectives. And so I need to start by saying that I do have a very specific perspective, which is I tend to represent hospitals. I'm generally representing administration. I'm representing legal. I'm representing management. Hospitals that are employing physicians and nurses and other clinicians and also non-clinicians. So that does give me a different perspective. So with that in mind, let me talk a little bit about what we saw in the workforce during and coming out of the pandemic and how I think it may fit with some of the things that my colleagues have already talked about. The first thing we saw, what was colloquially referred to as the Great Resignation, specifically in acute care throughout the country. There was some thought at points it was the Great Retirement, but actually statistics haven't borne that out. It was probably somewhere, the statistics I've seen have been 7 to 10%. Instead, I like to think of it as the Great Realignment, which is, it's not that people necessarily fled healthcare, they fled hospitals. They fled the stress of what was going on during the pandemic. As a result, there were terrible staffing shortages. Those continue to this day. Hospitals and health systems had to turn to a lot of different alternatives. Agency nursing, for one. And again, it's not just a nursing issue. I mean, there are shortages across the board with nurses, other clinicians, non-clinicians. But agency nursing is a great example, which then increased the cost. There also has been generally, and I think I heard Mariah with the data confirming it, but anecdotally, we've really seen this, which is in acute care, we seem to now have a younger and less experienced workforce, which is kind of putting more pressure on the system. There were some things during the pandemic and coming out that from a technological perspective helped. I think telehealth, which was already developing, was accelerated by the pandemic. I think there have been some tremendous successes, both at the nursing and physician level with telehealth. There has also been remote work, and the results from remote work have been much more mixed. What we have been finding over the last year or two is a lot of healthcare companies are pulling away from remote work. What they have been finding is that remote work works well with much more experienced employees, does not work real well with newer or junior employees, and it is horrible in terms of training. And so when you've got a workforce that's becoming younger and less experienced, and you're trying to use remote work, it becomes much, much more difficult. Remote work also has costs associated. Just last year, I worked on a project with one of my hospital clients. They only have hospitals in Maryland. And they discovered that from the pandemic through 2024, they were now employing employees in 39 different states. As they realized that, they also realized that their compliance was out of whack, and the payroll costs alone of the payroll taxes they had not been meeting was massive. As a result, they had to change their policy. They actually now will only allow remote work in the Mid-Atlantic. And so if you decided to move to Idaho or California, you can't work for that hospital anymore. So those things have had some kind of mixed results. What has also come out of it is what I have heard termed the age of grievance. And again, this is the perspective of management. What we have seen over the last 3-4 years is a huge increase in litigation, specifically whistleblower claims, wrongful discharge claims. We have been seeing nurses and physicians who 10 years ago might not have been willing to bring a claim are now much more willing to bring those claims. Again, there is a cost associated with that, in defending that litigation that impacts the health system. So words are important. I know I'm a lawyer, so I make my living off of words. I use a phrase like the age of grievance, and it implies something. We use a term like betrayal, it implies something as well. Betrayal implies, I went and looked it up, treachery, duplicity, and fault. So by using a term like betrayal, we're prejudging the situation. Again, Dr. Dean and I have had some interesting discussions. I'll be honest, I do not like the term betrayal because I think it implies something that I don't believe has happened. Specifically, what I have found practicing for over 30 years representing hospitals is that people go into healthcare, whether in nursing, whether physicians, whether administration, because they want to help people, because they want to help patients. I don't believe there is anyone in healthcare who does not have the ultimate goal of servicing patients. The problem is that healthcare has limited resources and resources that are becoming more and more limited each year. And the result is that there is a cost associated with everything. There is a cost associated with how you deal with your physicians, how you deal with your nurses. And those costs can impact the ability to provide care in other areas. So I thought a lot about this. I wouldn't use the term betrayal. I would actually use the word disalignment, because I think what has happened, and I think it was really accelerated during the pandemic and going forward, is that we really have a disalignment in terms of our different sectors in healthcare, in terms of how we should service patients and where those limited resources should be dedicated. It is, I handle individual cases. I have absolutely no suggestions for how to fix the system. But I will say that there is no doubt in my mind that the pandemic emphasized and accelerated and really widened a lot of the cracks in the system.
Thank you. Thanks, Rob. And what I think that's so fascinating about this conversation and why it's so important here at EU that we bring together these different perspectives is for our law students, or even many on Zoom, anyone in law, policy, advocacy, wherever you are, this, how we think, how we frame things, how we describe things matters. But even if we sort of say, well, we have disagreement about things, we can also go to the root and say what you each have said, which is we are aligned in the concerns. We're aligned in where we're seeing the cracks. We're aligned in the challenges. We struggle on how to solve it because these are complex matters, but that's why having us all be together and discussing it together is is the way forward. And especially for law students or early career lawyers, et cetera, to understand that you are representing a client, you're representing industry, but you're still serving a mission. And I think I'm a lawyer like Rob in the sense of representing a lot of hospital health systems. We feel we're representing a mission, even if we aren't at the front line as the clinicians who we really respect and admire for what they're doing at the front lines, the managers, the compliance officers, the lawyers, they are serving a mission as well. And so we're going to come back to this theme with whatever little time we have, just where is this alignment? There has been a disalignment, but what are we going to do about it? How are we going to find that common alignment to move forward? But I want to make sure, Karen, we get you plenty of time, and we do have plenty of time to hear your perspective of nurses, because I want to make sure that I feel like nurses are a critical part of this conversation. You have a slide, I think. If we want to just pass the clicker over, yeah. And we can come back to some more slides as well. Tell us about your role during the pandemic, because you were very much working on nurse training and preparedness. Where have we seen this all playing out from the perspective of, here, I'm gonna let
I don't know
someone else
how
figure
to-
it out.
yeah.
Here,
Of course.
Well,
Thank you everyone for being here. My name's Karen Drenkard, and I love the last panel, and I have just like rewritten my whole conversation around, like, I'm the example of glocal. I'm a nurse by background. I've worked in this area my whole career. I was the chief nurse at Inova Health System, which is a 5-hospital system in Fairfax, Virginia, for 10 years. And when the pandemic hit, I had moved into academia. I was the associate dean at GW School of Nursing, and I was the associate dean for community engagement and clinical practice. So I brought this lens of operations, 5 hospitals, 5,500 nurses. I led the command center during 9/11. And after that, the region saw an all hazards preparation approach to planning. And we worked really closely with our public health partners. It was exactly accurate, the last panel. They have been understaffed since I started my career. And even when anthrax came, which you only read about because you probably didn't experience it, but there were no public health providers. And so they came to us with 5,500 nurses and said, we need your help. So this concept of partnership is critical. So here I am as the associate dean. I have all these community involvement activities. We're doing all this mission work. I had 400 undergraduate students, 1,500 masters prepared nurses that were becoming nurse practitioners. So we had a large student body. And the dean comes to me it was March 3rd. The boat was in Seattle and the case is in New York. My colleagues and friends there were calling and saying, something's going on. And there's a really good network of nurse leaders across the country. So I think to the point, listening to our colleagues in other places, something's coming. So my dean met on the first week in March, and she said, they're going to cancel spring break, but don't worry, we'll all be back after that week. And then I said to her, well, I have, and my dean was a nurse too. And I was like, I have a different perspective, and I don't think we're going to be back after spring break. And then within 24 hours, she came back to me and said, the School of Medicine, the School of Nursing, and the School of Public Health at GW all need to give one person, like an FTE, for this response. And I have 175 faculty, but they're all academes, no disrespect, but they hadn't run a hospital. They didn't have the operational kind of chops that they didn't understand it really. So the dean said, will you go forward? So as a result, I had fabulous collaboration inside a school with medicine and public health, and actually the law school as well, because of the information that was brought before about vaccine mandates and can we mandate this? And then the hospital had a relationship. So here's what I did. So this was kind of the global part. I really understood the big picture. One of my best friends works at World Health Organization. There's an international council for nursing that we were communicating with. And what happened on March 20 was the very next day, all of the hospitals, including children's, said no more students are allowed to be in the training sites. So I had 400 undergrads that basically were finishing their senior year, no clinical. And the freshmen that were coming in, no clinical. So we had a sim lab, which is fine, but I will just tell you this, it's very different putting an IV in a mannequin than it is in Rob, okay? And I mean, the human
Thank goodness
body.
for that.
The human body just needs experiential practice, and they shut us all out everywhere across the region. So what I decided to do, I went to the dean with a proposal and I said, we have 400 undergraduates. We were working, I didn't get to speak to my DC counterpart, but we were working with the DC mayor's office. And we knew that testing needed to be stood up and eventually vaccines. So we partnered with the DC government on testing. And I set up, we had 2 sites, one on campus, and then we supplied student staff for the convention center testing site, and there were other sites. And then out in Loudoun County, we ran that whole testing center as well. And so I can say this with good confidence, at least there's 800 nurses out there now who know how to do COVID testing, which is not that big of a deal. And then, but can give IM injections, right? That's basically the only skill that they graduated with in person. But the other thing we did, which we did out in underserved communities in Northern Virginia, we did a lot of educating because of the last panel said misinformation, disinformation about vaccines. Even the students, like they were telling us, like they were getting their information off of like Instagram and YouTube, and no, they were not looking at the CDC website, nor are they looking at Hopkins data set, or were they looking at University of Washington. And so we had to redirect the students and then teach them what to tell people, because the mRNA vaccine, what wasn't shared this morning is that it was in progress already. It was being developed for Ebola. And they just didn't get to so warp speed was a little bit of a misnomer because the development of mRNA was already there. And the other misinformation that was just the worst was that it somehow manipulates your DNA, but RNA is not DNA. So it's like the messenger. And I just said to them, imagine you got an email that said your package is arriving. It's not your package. It's the message that the package is coming. And that just didn't get out. So that was one thing. So we gave over 10,000 vaccines. It was exactly what they said. The vaccines arrived before the vaccinators were there. They told us on December 18th that they were coming. Well, what holidays are major right around that time? And where are the students? Oh yeah, they went home if they could. So we started vaccinating on the weekend of December 23rd, and we vaccinated all of the student nurses. We vaccinated the hospital staff, as you recall, in all the hospitals. We were lining up healthcare providers and some of the operational things that would happen. So they would come in and you have a vial of vaccine. I don't know if this happened at Children's. And then at the end of the day, nobody showed up and there was vaccine left. And like 5 shots left. It was unbelievable. We were like, we can't throw this out. It was like such a precious commodity. So what we did and we partnered with a pharmacy out in Loudoun County. We literally went to people that were next on the tier to say, if you can get in the next hour, you can get a vaccination. Now, was that a public health decision? That was not. That was our decision on site to say, the more people we can vaccinate, the better off we are. Because as you recall, it was healthcare workers, it was utility workers, it was grocery store workers, but the people who were telecommuting, they weren't on the list. And the other thing I would say that was experiential was, I went to work every single day on site and most every weekend. The other 174 faculty worked remotely. And that just caused this kind of have and have not mentality that I think was replicated. So then here's my perspective. The system was already broken before COVID. It already was. There's cyclical turnover trends in nursing that have gone on for 50 years. We don't have all hazard preparedness plans for staffing. We have it for supplies, facilities, space, communication, marketing, everything else, but not for staffing. So it's really difficult if you have minimal staffing to then figure out how you're going to surge up, and we just don't have it. This is my opinion, not of any company or any group, but the fact that we did not have essential PPE resources was an absolute management malfeasance or malpractice or whatever you can say. It was not right. It was absolutely not right. So when they talked about the national stockpile, we've got to invest in that, if nothing else, because without the healthcare workforce, you can't help anybody. It's like the oxygen mask that you're supposed to put on first before you help your kids. That's what the PPE was. There was no shift in managing workload demands. The staffing they tripled the cost of nurses. So I felt like there was also, and they tried to, I'm not a lawyer, but they tried to like go to the trade commission and say they're there's a word for it, like scalping or something, I don't know, but like they shouldn't have been able to triple the cost. But so of course the nurses left to go be vacant agency nurses because they made 3 times their salary, and who could blame them, right? They paid off all their debt. And then lastly, I do want to say moral injury and moral distress is absolutely real. Your comments about why you become these professions is so true. So, but I will say that in the nursing profession now writ large, the term resilience has come to mean, wait, you mean it's on me? Like I have to be more tough. And that is not going over well. I'm just telling you, boots on the ground. Instead, there's literature coming out around seeing nursing as a human capital, not human resources that needs to be invested in. Yes, it costs money, but they're buying buildings, building buildings, buying CAT scanners, doing other things. And there's work now, and I'm leading a national committee at the American Organization of Nurse Leaders, and we're looking at the investment and impact in nursing. And we're looking to develop ROI tools that say you will get a return on investment if you invest in human capital. So we're very excited about that. And then I have some good news, even though all of this felt like doom got to me. I'm in hundreds of hospitals. I have been for the last decade because I also ran the credentialing agency, and I probably have been in 400 hospitals. They're investing in well-being programs, and they're serious about it. I made rounds yesterday at a Nova Alexandria hospital, and I met an employee assistant program counselor. She has a master's in counseling. She was making rounds on the units live time. Like you wouldn't have seen that really before COVID. You would have had to go to a secret website to get an EAP appointment, but they're pushing things out. The technology innovations, the use of AI, reducing the administrative burden, the virtual nursing, these are all kind of things that came. And there are systems now that have a better staffing response because they've developed inter-hospital, their own agency. And then, so I think there's things coming, but we did not capture lessons learned. We did not keep the regulatory improvements, like the scope of practice for nurse practitioners got completely, like you could practice full scope in every state during COVID. And then as soon as the pandemic ended, they said, okay, now nurse practitioners practice differently in every state except for in the VA. And they didn't, they just reverted back to 2019 as far as the regulations went, which was just so like, it seems very non-learning based, right? Like why we need to learn from our lessons. So I'll stop there, and with thanks to the other panel, but local. So this is my takeaway. Wherever you are, in whatever practice you end up in, you can think big and you can say, if I was in charge of CDC, this is what I'm going to do. But what you end up having is at the local level, the set of circumstances that you're faced with, and you can act locally. I think we made a really big difference. We helped validate the Medical Reserve Corps nurses because they all volunteered to sign up, but they hadn't given a shot in 12 years. We worked with the Capitol Police to do the testing with them. And these were all students. So I felt like, you know, in my small corner of the world, we made a difference in the area that we had. And lastly, I want to say thank you for inviting a nurse, because the whole thing was they got 180 million vaccines to the sites. Who do you think gave them? Yes, EMS in some areas, but for the most part, it was nurses that were giving shots. So thank you for that.
Thank you all. Well, listen, I think that might be the perfect way for us to wrap up. We're just at time. But if you'll bear with me, I'll kind of tie up some themes there. You know, we talked about data. We talked about storytelling. We talked about the language we use. We talked about clinicians at the front line, but also the administrators, the decision makers when it does come to funding. How am I going to fund this? How am I going to manage this? There is distrust within, not just from without, right? And so, but I'm hoping we can have this takeaway of one, that there's a lot of alignment on the issue, that this is a challenge. There are grievances. There is burnout, betrayal, whatever words we want to use. We definitely are at almost a cliff here, I believe. I also want to note that this panel is a little bit different. I know we didn't have a lot of chance for a lot of additional discussion, but it was important to us to bring all these perspectives together. And even then, we know that we haven't even peeled all the layers here. Does anyone want to add anything here, just as we wrap up?
So I have one quick thing, which is that I think it's really important that we make sure we listen to who's on the folks who are on the ground level, who are at the grassroots, because dictating to them what they're experiencing, what they're feeling, what language they should be using, I think is problematic. And betrayal is what they're feeling. And we know that 85% of it is usually unintentional. It's not whether or not you betray. We're human, we'll do it. It's what you do with it after. If there are no attempts at repair, that's when the problem happens.
Anybody want to add a final thought? We're in time. Oh, quick question, maybe? I know we've kept some students. That's great. Well,
Just a quick question. Thank you all for being here.
very loud.
Oh,
Yeah.
sorry. Just a quick question. Thank you all for being here. I feel like this is an opportunity we don't get very often to hear from so many people across different fields. You mentioned just a second ago, a lot of us, like when the pandemic started, we were either an undergrad, high school, college, and we all got sent home. Some of us, like myself, I started working as an STNA at like a low funded, like very understaffed long-term care facility. And so like you mentioned the moral injury and things that, and you know, the disalignment or however, you know, you call it, how would you recommend, even in the legal profession, how do we confront the lack of support that we might encounter, you know, with the real need for patient care, like practically, whether that's as a nurse or a lawyer, how have you done that and how would you recommend it?
Since you're on the ground.
Yeah, no, it's interesting. I think similar to what you were saying before of all of the sort of accommodations that were made during the pandemic to rise to the occasion suddenly got cut, and we had to regress back now to 2019 rules, but we're living in an environment that's no longer 2019. I mean, the world is forever changed, as it did after 9/11, and there were new rules in place, and now sort of accepting how do we reframe and relook at policies, laws, health, even in my emergency department, different ways that we operate and communicate with families who are now in a different, have a different framework for what they expect of healthcare. And so I think just really to piggyback on what was just said, there needs to be connections between what is happening at the front lines, what we are experiencing as clinicians when we're in the one-to-one relationship, but then what's happening at the advocacy levels of these global perspectives, the national organizations, the federal government, trying to sort of bridge that is, I think, the ultimate challenge for all of us in the room, no matter where you end up in your career, whether it's in a law school professor or in the federal government, you know, remembering that is the essence to drive what decisions you make and how you make that permanent, because it has such long lasting impact.
Yeah, one of the strategies that, I don't know, sorry, one of the strategies that a lot of hospitals, but it hasn't gotten into like nursing homes, is what's called shared governance. And so I've seen, they stopped during COVID, but they've resurged tremendously, where like you can sit on, and some of the councils that they have are looking at, you know, healthy work environments and how they can change the work environment. And then that's frontline clinicians. And I know Children's Hospital has a lot of councils as an example. And then that gets brought forward to the leadership and gets included in strategic planning. But fundamentally, everything that was said today about the fragmentation and the brokenness is still there. You know, it's very frustrating inside when you can't get a patient what they need because of the regulatory requirements or the payment system or the lack of accessibility of services. It's just not uniform. I mean, we're very lucky to live here, but if you go just, you know, 100 miles west to West Virginia, it's just, it looks like a whole different country. So we won't open disparities.
If you want to go to wpchange.org, there is a national framework on burnout and moral injury that also has a corresponding action framework that takes it down to these levels. It mentions shared governance, and there are a lot of other strategies there.
Thanks for the question.
Yeah, I just wanted to share one framework that we consider a lot when we're talking to health departments and how they might want to change their workplace environment to deal with a lot of the issues we've talked about. Because they don't have the money or the staffing to make these changes, we think a lot about the big P and the little p policies. And so I would encourage all of you, as you're kind of thinking about these issues, is how can we be creative to create these little p policies that don't require as much, but still make just as big a difference in a lot of cases.
And I guess finally, real quick, pinging off of that, there's an old saying, all politics is local. In what I do, there's a similar phrase, which is all workplaces are local. If you look at issues with employee morale all the way to union organization issues, and you survey employees, what you'll find is 90% are making their decisions based upon their local situation, based upon their specific manager. And so when you talk about big P and little p, sometimes the little p is the most important thing.
That is a good way to wrap up. Thank you so much. I really want us to thank the student leaders again, Julia and Harrison. Tamina, you're fantastic in supporting the event. Our panelists, what perspectives they bring, how important it is to learn from them. Thank you all so much. Couple of quick, we have a couple more events coming up. March 25th, we have a book talk on We the Men. The author, Jill Hasdy, is going to be with us. And then April 11th, a one-day symposium on youth health law issues. So that's another area we're going to touch on reproductive health, mental health, many different areas intersecting with youth health law. Maybe some of our panelists will come back and join us for that because it's going to be another great session. Listen, please join me in thanking this fantastic panel. And thank you to the Zoom audience that stayed on with us as well. And we're going to go ahead and wrap up the event there. Thank you all.